Hello, everyone, and welcome. The title of the presentation is Smart Pump Interoperability, the Current State versus the Future State. Our moderator is Rachel Vitu. Rachel, a co-author for the presentation, is the Director of Clinical Consulting and Services for B. Braun Medical, where she has extensive experience in creating educational programs and services to promote infusion therapy safety and best practice. As an advanced practice nurse certified in HIT, she's authored numerous publications on smart infusion pumps, clinical practice, and the environment of care. Rachel leads the clinical integration and analytics team in delivering integrated solutions and achieving positive outcomes. Rachel, welcome.
Thank you. This presentation will provide attendees with a foundation to evaluate their infusion pump clinical workflows in preparation for smart pump EMR interoperability. Common challenges occur when moving towards standardizing these common workflows, and workarounds can exist. So various strategies will be presented on how to mitigate issues and prevent possible workarounds. We will conclude the presentation with methods for measuring and sustaining success. Our speakers are Lori Belford and Sarah Johnston. Lori is Manager of Clinical Integration for B. Braun Medical. She leads the development of standardized processes and procedures for smart pump interoperability. She has a diverse background, including infusion system device consultation, critical care nursing, research, and pain management. Lori is a member of the Healthcare Information Management System Society and holds a graduate certificate in healthcare informatics. Sarah Johnston serves as Principal Data Scientist and Clinical Consultant for B. Braun Medical, and she has a background in ICU and medical surg nursing. Her focus is in developing IV pump data analytics for business intelligence tools, infusion management software, and she also assists with the smart pump EMR integration, implementation, and establishing key performance indicators. Sarah is a member of the Alabama chapter of HIMSS and the American Nursing Informatics Association at both the national and state levels. Lori Belford, Sarah Johnston, and myself are full-time employees of B. Braun Medical. This activity has been approved for 1 contact hour for nurses. A link to obtain your certificate will be available at the end of the presentation. Accreditation information is listed here, and support for this activity has been provided by B. Braun Medical. I now introduce our first speaker, Lori Belford, to begin the program. Lori?
Yes, thank you, Rachel. So the learning objectives for this session include identifying the top challenging infusion pump workflows and to standardize them for interoperability, describe the challenges that occur when moving from the current state of infusion pump workflows to an integrated workflow, identify strategies to mitigate workarounds associated with those workflows, and then name 3 ways to measure success. So first, let's talk about why an institution might choose to integrate their smart pumps to the EMR. And institutions often choose interoperability to improve safety, efficiency, and revenue capture. So essentially, interoperability can help close the loop on medication safety and efficiency by sharing the data between the 2 systems. So this is accomplished through wireless transmission of infusion data from the EMR to the infusion pump and from the pump back to the EMR. So that's auto programming and auto documentation. So if you look at the top of the diagram, the process starts with the physician. So the physician will complete the patient assessment. The physician determines what the medication is and then enters the order via a computerized order entry system, or CPOE. A pharmacist then verifies that order in the pharmacy information system, and once that's verified, it makes it available to the nurse in the medication record to administer. And then to start the infusion, the nurse uses a barcode medication administration process, or BCMA, by scanning the patient ID band and the barcode on the medication. And that scanning process automates the verification process and assists the nurse in confirming the 5 rights. So is it the right patient, the right medication, the right dose, the right route, and the right time? Now, with interoperability, there's one additional step that's added to the nurse's workflow, and that's scanning the pump barcode to link the medication, the patient, and the pump. The nurse will then administer the medication from the EMR, and then the infusion parameters are wirelessly transmitted to the pump for the nurse to verify and accept. And then infusion data like start times and stop times, the volumes infused, titrations are all sent back to the EHR. They have to be validated by the nurse, and then they're recorded electronically. So now you've not only validated the 5 rights, but you're including a 6th right, which is the right documentation. And that makes it a safer, more efficient workflow. Now, why is this important to stakeholders? Well, ultimately, it improves the delivery of healthcare by making that right data available at the right time to the right people, and then that essentially closes the loop on medication administration. It's important to note that you do need base parameters for auto-programming to occur, so you will need an interface between the pump and the EMR, and that's important because the pump and the EMR need to speak the same language. And speaking that same language, those standards allow the 2 different systems to communicate effectively, and that's what makes implementation easier. Second, there needs to be an order in the EMR to send those infusion parameters to the pump, and the order does need to be first verified by the pharmacist. And then you also need the medications in the EMR formulary to map to the pump drug library. So what does that mean for our discussion on workflow? It means that you'll need to review and define in detail all of the order processes. So it's important to know the limitations of each system, including the EMR and the pump. So just like there needs to be standards in place to accomplish bidirectional communication between the pump and the EMR, there needs to be the same structure and rules across the organization when it comes to the workflows of medication administration. So the more variability you have in protocols, for example, how you handle flushes or titrations or boluses, the more likely you'll have workarounds and non-compliance. This directly impacts clinical practice because the more you can standardize your clinical practice and the pump workflows across the organization, the more successful you'll be. Now, these types of workflow changes aren't just nursing or department-based, but they impact all disciplines whose day-to-day work is affected by interoperability, and therefore they should be represented on a team. We see various institutions include representatives from project management, there's pharmacy, nursing, physicians, you'll see clinical informatics and IT, clinical application analysts, clinical engineering, there's data analysts and clinical education specialists. There are a lot of people involved in this project, but it isn't a small undertaking. Now, that being said, not all team members will need to be intensely involved at the initial stages, but also keep in mind that early involvement can help build understanding. It can also improve collaboration and also reinforce that culture of safety right from the start. What is a system development lifecycle? So if you've been part of an EMR system rollout, you may have heard this term, and an interoperability project can take a bit of effort to develop, and the system's lifecycle breaks it down into distinct phases. So there's planning phase, creating and testing, deploying, and then of course there's continuous improvement. So I'm going to briefly touch on these phases and what's in them a little bit, and then Sarah is going to dive deeper into the infusion pump workflows that I've been mentioning. Now, the initiate phase is essentially the planning phase. So during this phase, you want to determine the scope of the problem and then identify the need for change. So what has brought you to the table today, and why do you want to integrate? Perhaps you've seen an increase in infusion-related errors with the smart pumps. Infusion centers could be losing money because of inaccurate start and stop times. Or it could just be that nurses and physicians are struggling with accurate and timely documentation. So establish the key performance indicators up front. So you can measure that success of the project after go live. Know what the goals are going in, what you want to measure so you can ensure success. In this phase, it's also important that you'll determine which resources are needed, the cost, the time, and then if there are any other competing projects that may possibly delay your timeline. The analysis phase, during this phase, the project team ensures that the system requirements are helping the end users and then how usable it is to them, and if it meets their needs and expectations. So if it does not meet their needs, they won't use it. So that means getting all those who use infusion pumps involved in the process and then doing a thorough analysis of their workflows. You'll also need to do a thorough assessment of the wireless infrastructure as well as an analysis of your hardware. So for example, do you even have enough pumps for this process to occur? Are the nursing workstations that you have relative to where the pump is placed? And in that case, are the scanners wired or wireless? You will also have to do an assessment of the drug library within the pumps. So just like I mentioned, how important it is for nursing to standardize their workflows, it's equally important to standardize the medications in your drug library and EMR formulary. Interoperability becomes more challenging if medications are ordered and prepared or administered differently across the health system. The design, development, and test phase is the phase, this is really the phase where the real meat and potatoes of the project happens. It's heavy for pharmacy and for nursing. For the drug library, it means mapping all of that EMR formulary records to the drug library in the pump and then testing each entry. And this is typically a joint effort between your IT pharmacy and nursing. Nursing and pharmacy are working together really to ensure that this new way of programming is usable to them. The super users, the nursing super users or subject matter experts will often do the testing of the map drug records, which gives them the ability to provide input and also to get used to that new way of programming. We often see that nurses who are involved in testing are then the super users for Go Live. Nurses should also be involved in negative testing. I think this is a piece that is often missed or eliminated. And it's an important piece because it's not enough for them to understand the workflows that work, but also where they fail, why they fail, and then how to respond to failures. Also in this phase, nursing will be standardizing, testing, and finalizing all their infusion pump workflows. So if you can simulate a real practice test environment with a bed, a pump, and a workstation, so they have a true understanding of how it will work when they get out on the floor. In the implement phase, most of the work is complete, and now it's time for training and go live. Training should always be hands-on with a pump and a computer. There's no question you'll have the best success at go live if nurses can see and do in an environment that closely mimics their current state. We've also seen accounts develop online courses in adjunct to that hands-on training, which really made for a smoother go live for them. And make it mandatory, otherwise they are going to be faced with a new workflow at the time of medication administration, and that's obviously not ideal. Now, it may not be possible to get 100% of your nurses to education before go live, but really important that you strive to get there. And then let's just talk about the super users a little bit more. They're a very important part of the project. It's important to engage them early to create accountability and incentive for integration. Super users should be part of the testing events, like I said, and also those workflow decisions. So eventually they can become the support at the elbow for go live. The super users should be the champions of your smart pumps. Those that know and understand the pump workflows now, they'll be the best resources during the integration project and at go live. And then also during go live is when you begin to measure compliance. Therefore, keep it simple for nurses to report issues. If it's too cumbersome, they won't report it and they'll likely just stop using the solution. And when planning a multi-facility go live, you may want to consider starting with one facility first, ironing out any issues before you move on to subsequent. And the support and continuous improvement phase. This is where you help those using the system to the best of their advantage. So have a good understanding of the EMR vendor compliance reports, but also understand the reports and analytics services that are available to you from the pump vendor. You'll begin to report out those KPIs to the stakeholders and then make improvements where needed. Nursing workflow. So what do we mean when using the term nursing workflow? Well, workflows are often used in clinical practice and they're used to accomplish patient care goals. And when we refer to infusion pump workflows, we're referring to the steps the clinician takes to deliver medication through an infusion pump. So, for example, how nurses administer intermittent infusions or how they flush a line after an intermittent infusion, how they prime a line, how they may address overfill, how they bolus or titrate. There's a large list for infusion pump workflows. And during the analysis phase, the interop team will need to understand how each department is delivering those medications through the pump. So the team needs to have a solid understanding of those current practices. So what is working well with them now and what doesn't work well. Assessments can typically come in the form of questionnaires, workflow meetings with the subject matter experts, and oftentimes more effectively just through direct observation. Now, when you're doing your assessment of the current state, you're guaranteed to receive a multitude of answers from just a few nurses. So if you multiply that variability across an organization, interoperability can sound like an insurmountable challenge. So it's not uncommon for conversations around these topics to take months out of the integration timeline. For example, you may need to make adjustments to your policies or involve quality and governance committees, and they at times only meet monthly. Any work that you can do before beginning the project will save you time once the project has started. Best to implement small changes early as opposed to waiting for large changes that go live. It'll be a much smoother and easier process. Okay, what is a workaround? Well, typically nurses will find a way or shortcut or another way of doing things when their current workflow becomes too complex or they need to save time. Well, we're excellent problem solvers and innovators, but workarounds can cause unintentional risks in patient care. Therefore, it is imperative you fully understand their current state and any challenges that they're experiencing to help standardize those workflows and then minimize those workarounds. The key really here is to integrate changes with as little disruption to their current workflow as possible. The more you have to make changes to their current workflow, the more challenging it becomes. Now, that's not to say there are some areas that may experience a significant change, and if that is the case, You'll just have to have more development in the training curriculum and support at Go Live. But keep in mind, the change takes time. An integrated workflow is not faster in the beginning. It takes end users time to learn the process. Sometimes accounts go in thinking it's going to be faster and quicker, and it's not necessarily the case. It does take time for them to get used to this new way of programming. So I'm now going to pass it on to Sarah, who is going to dig a little bit deeper into some of those workflows that I've been mentioning.
Thank you, Lori. So we are going to dive deeply into specific workflows for this next section. Specifically, those are going to be administering fluid boluses, titrations and rate changes, flushing after intermittent infusions, and accounting for bag overfill. And then also transferring patients between in-scope and out-of-scope units, and then other outlying things like monitoring your errors. So let's start with primary IV infusions. Specifically, the ones listed here, every nurse has hung a new bag and most likely hung a subsequent bag. Critical care and ED nurses will be more familiar with fluid boluses, medication boluses, loading doses, and titratable medications. Although I imagine, as Lori stated earlier, if you put 5 of them in a room, you're going to get several different answers based on the acuity of the patient population they deal with. And then we look at the edge cases, like auto-programming outside of the drug library. Does your pump have that capability? And what's the fallout of really adopting that type of workflow? And how are you monitoring for that after go live? And then when we talk about that, that leads us to medications that aren't in the drug library. Maybe a medication was missed when the drug library was built, or maybe a medication wasn't added to a care unit that uses that medication. We are humans, so we want to double check all of these things as we go through the build and do proper testing. There are also situations where you might have a medication that you intentionally leave out of the drug library, like a chemo med. You might have one patient who needs that medication once, and then you may never give that med again. Do you want to go through the burden of updating your drug library in order to accommodate that one medication that one time? Or perhaps you have a research study and that medication name on the pump needs to be blinded. Things to consider as you move through developing your drug library for integration. And then we talk about patient weight. It sounds very simple, although it isn't. For a physician, when they're placing an order, you have to ask, which weight are they referencing? Is it an admit weight that can often be guessed? Is it an actual weight from when the patient was weighed in the bed? A dosing weight based on the changes they might make to the weight based on their size? Or a daily weight, which is updated every day? And a medication order might last for several days on a patient. And then which one of those is being sent to the smart pump? And then how does your pump handle being sent a weight that's different from what the previous weight was? So let's dive more deeply into our first topic, fluid boluses, and take a moment to really define the difference between a fluid bolus and a medication bolus. A fluid bolus is a large volume of fluid given at a rapid pace, whereas a medication bolus is usually a small bolus given IV push from a bag that's already hanging or pushed. Focusing more specifically on the fluid bolus, let's consider the challenges. What are your EMR and pump capabilities? It's always important to ask that question first. Before you dive into what your future state might look like, you need to know what that capability is. And there are usually a few ways to accomplish the same end goal, but which is most appropriate for your practice and your standards? An example is to consider an order for normal saline 500 mLs over 30 minutes, and that translates to 1,000 milliliters an hour. Not that many pumps on the market can infuse at that rate. And then the question you have to ask, do we take that out of scope? Or on the EMR side, is there a way on the back end to translate that 1,000 mLs per hour to the 999 that most pumps can handle. And then the question is, where is the medication actually coming from? Is it a bag that it's already hanging? And then how do you account for that new order? How do you marry those two together when that bag has already been hung and charged? And what does that documentation look like for the previously administered bag and its order versus the one you're now trying to give in that bolus? The cleanest workflow is to have a new bag, new tubing, and a new pump. But when you think about emergent situations, do you have the time to grab that new bag, that new pump, before you need to treat your patient? Step one is always take care of the patient. And then in that emergent situation, is there an order? Is it verified? As Lori outlined, you need both of those things to take place in order to do smart pump programming. So moving on to our next topic, titrations and rate changes. And like before, to really talk about that, let's define the parameters. Titration is a nurse-initiated patient parameter-driven rate change, whereas a rate change in smart pump programming is where a physician changes the order that exists from one fixed rate to another. An example of this is if a physician comes in, establishes that the patient's renal function has changed, and wants to change their normal saline, their maintenance fluid, from 125 milliliters an hour down to 75. Whereas a nurse-driven protocol for like heparin is changed based on a lab value or timing of when a medication should be delivered at what rate. And nurses do that, and it's all written into one order. And then one of the questions that you have to ask there is, again, what are your capabilities of your EMR and your pump? And what are the pros and cons of adopting different types of workflows? For titrations, can you send an update order from the EMR, and can the pump accept it? Let's focus on rate changes for a minute. You need to ask how and when you can initiate the new order. What information comes across the interface when that order is sent? And is the volume of the medication part of the message? If so, or if not, how does that work when you need to initiate a rate change in the middle of a bag? I don't think I've ever had a physician change an order at the time that I also needed to hang a new bag. So you have to be able to accommodate those variances in what's hanging and what needs to be administered. And then, of course, which orders create a new charge for the patient? I want to associate a new order, but I don't need to charge the patient because I'm using a bag that I've previously hung and previously charged them. You have to ask your EMRs how they're going to handle that and what the ramifications are of that type of workflow. And then when titrating to effect, the primary question you have to consider is, can you have a ranged order in your EMR? And can updates be sent and received from your smart pump? And this opens up that question that Lori mentioned earlier, safety versus expediency. It is not faster in the beginning, and you have to account for the nurse will need a computer, a scanner, and the ability to scan and send that information to the pump. So that changes your expediency versus the safety of actually programming that smart pump with your auto programming. But it all comes down to step one, which is take care of the patient, and you want to do that timely and efficiently. So now let's shift from talking about primary infusions to intermittent medications. And let's focus on intermittent medications, which are often secondary medications. And I stated that way to point out a few key points. First, not all intermittent medications are secondary, but all secondary medications tend to be intermittent. By intermittent, I mean medications that are scheduled and usually reoccur, such as your vancomycin, which will happen on a Q12-hour or a Q24-hour schedule. And these come in two different forms. You have dose over time, where you have a specific medication dose to be administered over a specific time, or a rate-based medication, where you have a volume order to be administered at a specific rate. And these medications can be given as primary infusion or as pictured as secondary infusion. For integration, you have to consider how to flush the tubing for those that are primary and how the carrier fluid is ordered when they are secondary. And finally, you see overfill listed. This, of course, refers to the additional fluid in the bag or fluid that is added when the medication is reconstituted. So let's dive deeper. We start with flushes. As always, you have to consider what the capabilities of your EMR are and what the capabilities of your pump are, while also adding the challenge of standardizing that workflow. First, do your intermittent medications hang as a primary? And if they are, flushing is now part of that equation. And are they flushing, or is that documentation lost? Or are they using part of the medication, losing part of the medication because they're leaving it in the tubing and not having it flushed when the infusion is complete? And then how can the flush bag be ordered? Is it nurse or physician driven? Who can insert that order, have it verified by pharmacy, and administer it to the patient? Or is your protocol to have certain intermittent medications hung as a secondary? For instance, those that are less than 200 or 150 milliliters. And if maintenance fluids are already hung, do your nurses use that as the carrier fluid? Or is it running at an appropriate rate for your intermittent flush? And if no maintenance fluid is ordered, how do you accomplish this? Again, is it a nurse or a physician-driven protocol? And what should the rate of that flush be, along with what's the total volume that should be administered to the patient for that carrier fluid? And do your nurses change the VTBI when programming a medication? We have to think of the ramifications on the EMR side when you're administering something like, as listed, 1 gram and 250 of a medication, and the nurse only administers 240, or potentially for overfill, 260 mLs. And with that being said, let's dive deeply into overfilled medications. Along the same lines you consider when nurses decrease the volume as to avoid air, you must also consider when a bag is overfilled or reconstituted and therefore has a larger amount. Consider how your nurses are currently administering that additional volume and how this affects that documentation. Ask your EMR, what is captured and what is documented? And nurses account for overfill in different ways. One is by adjusting the VTBI. And how do they change it? Is it consistent? Are they changing it by 10 mLs, 5 mLs, 20 mLs? And when you're integrated, the amount of input may change the calculation of the medication given on the EMR side. Do you update the formulary in the drug library to accommodate for this overfill? And this can be a pretty heavy lift for pharmacy. But when you're considering that lift for pharmacy, you have to consider all patient populations, such as infusion centers. And for them, that lift may be worth a lot for their ability to program and administer their fluids. So now let's dive into more outlier workflows, like emergent situations. Step 1, take care of the patient. And then determine when you're taking care of the patient and those actions done during that emergent situation, how your vendors can accommodate retroactively associating your infusion pump in your orders to bring in the timestamps and the titrations that have happened during that emergent event. And then we'll cover the rest of those listed on this slide in the upcoming slides. So association after transfer. What is your first question? What are your system capabilities? What can the EMR accommodate, and how does your pump function during those accommodations? What is the hierarchy of flow you set as you set the scope for your EMR, facility, or unit level? And I ask that question because you might have a situation where you have your pre-op, intra-op, and post-op all as part of one care unit within your EMR. So if you decide that intra-op is out of scope, that pulls post-op and pre-op out. And then what is that lift for if you decide to break that out into separate care units in your EMR and just to have them in scope for interoperability? Where is the win and how much work goes into that? When documenting, timing is key. So you want to think about your transfers from scope to scope. And one that I like to consider is walking through an ED admit. On less critical patients, there tends to be a bit of lag when they're moving from one department to the other. So you might have an ER nurse call report, and then there is a lag between when they call report and when that patient's actually transported to that new nurse, and when that ED nurse terminates her documentation on that patient. And then once that patient arrives in the new unit, is that patient transferred in the EMR? Is the information there for that patient to be assigned to her so that she can begin documenting at that time? And that's an in-scope to in-scope. Then we consider in-scope to out-of-scope and how nurses use the volumes that are listed in your drug library. Are they scrolling through the smart pump to say, this is the volume infused for my shift, and then documenting that? And if they are, what we've seen with interoperability is that nurses in scope for auto programming stop clearing those volumes in their pumps, or might stop clearing those volumes in their pumps. So when they go from in scope to out of scope, that out of scope nurse really needs to look at what that volume is and make sure that it's cleared at the time she takes possession of that patient. So when she charts her volumes infused, they're as accurate as they need to be. And that goes back to your system capabilities and how the EMR actually consumes that information from the smart pump. So along with considering volumes from unit to unit, it's important to review the limits of your dose error reduction software or your drug library limits. First, know the limits of the software you have. How many care areas do you have? And how well differentiated are those care units for your soft and hard limits within your medications? And then when you're moving from unit to unit, what is the burden of changing the care area during that transfer? How does this affect, and also how does this affect the association in the EMR? So if you change the care unit in your pump, do you have to stop infusing the pump? Do you have to stop and clear the infusion on the pump? And how that really processes within the smart pump and what gets transmitted to your EMR. So finally, we're going to talk about errors. And really the first question you ask is, what are the capabilities? And what are specifically the capabilities to report those errors? You'll see a lot of errors during your journey in your mapping your EMR formulary to your drug library, but not all of them. So I recommend that you ask your EMR and your pump vendor for a list of all the potential errors and try to create them. See what happens when you break the workflow. And this will show you what an error message really means. And then if you can update the wording, that's a great option so that when you go live, your nurses have the wording that means the most to them. For instance, we might say secondary or piggyback, and that might throw nurses for a small loop when reading an error message. Lori mentioned it earlier, we call this error testing, this creation of errors, that workshop, negative testing. And this is a great way to hone your super users and have them create all the errors in as many ways as they can. That way, when you go live, super users will really be armed and have that experience and may be able to recognize more quickly where in the process the end user got caught up. Then at go live, be armed also with solid reporting. How often is each error occurring? Lori mentioned earlier that you would want to keep the reporting of issues as simple as possible so that end users have the time to share their feedback, but don't rely completely on that. So it goes back to our previous question. What are the capabilities? What reports can your EMR and pump vendor offer? Good troubleshooting comes down to knowing what the issue is, and this comes from good super users, simple reporting, and compliance reporting from your vendors. Now, let's go back to Lori to talk more about error reporting and how that can help you achieve your KPIs for continuous quality improvement.
All right, thank you, Sarah. Thanks for reviewing the common workflows. Now let's conclude with how to measure and sustain success. And as with any continuous quality improvement project, it's critical to know what your goals are going in, whether it be safety, efficiency, approved revenue. And then you want to establish those baseline metrics at the beginning of the project. So we have a few key metrics here. Drug library compliance refers to using the dose error reduction software on the pump, and that can improve with auto programming. Auto programming compliance indicates how often clinicians are attempting to use the feature and whether or not they're successful. And comparing this across departments can help you identify if there are challenging medications or workflows that need to be addressed. Interoperability allows for infusion end times to automatically be populated into the EMR. This not only documents more accurate volumes infused, but it also increases the ability for the hospital to capture infusion medication charges and increase revenue. And then a primary measure of safety would be a reduction in infusion-related medication errors. Here are some examples of how smart pump interoperability can impact safety. So as you can see, there can be exceptional outcomes as a result of reduced manual programming, which includes a significant reduction in infusion-related medication errors, programming keystrokes, and drug library overrides. It is important to note, though, that outcomes like these are not typically achieved through the technology alone, but through active engagement of the project team, continual monitoring, implementing targeted interventions, and providing shoulder support and ongoing education. For example, in the facility that reduced their infusion-related medication errors by 50%, they had nursing informaticists and unit-based super users conduct daily rounds and provide hands-on help and continual reinforcement. So eventually, the staff gained the confidence with the workflows and how to troubleshoot the issues on their own. Reinforcement also occurred through electronic newsletters, they had team huddles, they sent out quick reference guides, and unit-based competency. Smart pump interoperability has also resulted in enhanced clinical practice, achieving high rates of drug library compliance and auto programming compliance. And this was done by providing clinical rounds and troubleshooting in real time. And they did this as often as daily until they met their targets. Eventually, they moved to weekly and monthly for an indefinite period. Smart pump interoperability can help reduce initial pump programming time and increase infusion charge capture by automatically sending that documentation to the EMR. And in this example, having an infusion end time automatically populated into the medical record increased the hospital's ability to capture infusion medication charges in their outpatient departments by as much as 25%. Lastly, to achieve these outcomes, it's important not only to set goals and establish achievable targets going into the project, but also allocate the appropriate resources to monitor your metrics long-term. Remember, this is a long-term continuous improvement project that requires constant vigilance and a systems approach to achieve and sustain success. So we would like to thank you. This concludes our CE program. I am now going to pass it on to Rachel, who will tell you how to obtain your CE credits.
Thank you, Lori. Again, this educational activity is approved for 1 contact hour. To obtain your CE credits, go to the site listed here. You will need to register at the site, complete the evaluation and the post-test, and upon successful completion, you'll be able to print out your certificate of completion. Support for this activity has been provided by B. Braun Medical. Thank you for attending our presentation.